Hi, everyone. Good afternoon. I am from University of Chicago. I'm an associate professor there in radiology. I'm the director of pediatric neuroradiology there. I read adults and children. We don't have the largest peds hospital in Chicago. I used to work at the other competing children's hospital where we have a lot more little patients. So we do a good amount of adult imaging, as you can imagine, you see. I want to first thank Dr. Grant for inviting me to be part of the speaker series today and for the whole week, and also the organizers of ASAP for a wonderful conference as always. So I'm going to offer you a neuroradiologist perspective. Let's revisit the fundamentals, and I put Chiari 101 in air quotes or quotes because I don't want people to get confused with Chiari 1, Chiari 2. What's Chiari 101? Just in terms of 101, the basics, and Syringomyelia. All right, so just to get our sort of visual imagery and sort of tools keyed up, I put some fun images up. Any idea why I might be showing these symbols or these images in relation to our topic today? I don't know if anyone out there might guess. It's pretty sort of obscure, but once you see it, you'll probably sort of recognize what I'm talking about. Any guesses? They're both yellow. Very true. Both fruits. Brain and the spine symbolism. Oh, I like that one, actually. You're actually getting on the right track. So I'm going to unhide. So this is actually, I'm not going to be going through ultrasound for the rest of the talk because that's sort of hard to grasp in 25 minutes. But this is an ultrasound image of a fetus. And this is for some of the participants who've had babies out there. You may recognize a little bit of this. This is the placenta in the mom. This is the amniotic fluid. You guys can see my arrows, right? Yeah. Let me see if I can make this actually a brighter laser pointer. That might make it easier or harder. Let me know if that's not tracking well. And this is the baby's head. Oh, there's more of a lag. Let me switch back. Sorry. There's a bit of a lag with the I don't know how to, I think I can just switch it off. Okay, well, now I can't get it back to the arrow. So this is the baby's head, and we have the back of the brain is over here where my red dot is, and the front of the head is in the other side. And the ultrasound probe is obviously outside the mom's belly. And we have something that we call the banana sign. There's this like curved area back here. That's actually the cerebellum in the baby with a Chiari 2. So everything's sort of pushed back in the posterior fossa. So if you overlay that, that's the banana that I showed you. And then the other interesting part is in a baby with Chiari 2, the front part of the brain sort of collapses down a little bit. So it gives sort of a lemon shape, as you can imagine. The lemon has a narrower part and a wider part, and this actually gives you the lemon sign. So I teach my residents and fellows the lemon sign and the banana sign. So you're on the right track with the brain anatomy, at least. So we're not going to be talking that much about Chiari 2 specifically today, but a little bit of a mixture of Chiari 1 and 2. But I just wanted to throw that out there as a quick visual just to get your juices going. So this is me inviting you to become part of my my home office. This is actually my home office. I took this photo yesterday. So inviting you to be in my chair, and let's take a little journey through what neuroimaging is, back to the basics. Okay, so in doing that, as you may remember from prior years, I like to keep it interactive so no one falls asleep. So you guys can join in on the fun. It's just a few questions. You can get to it by website, pollev.com/Carina Yang 867. You can text 22333 and you text the message Carina Yang 867. Easiest yet, just scan the QR code and that should get you there. In doing that, I did a test question just so we can see if this all works, because last year there was a little bit of a lag. So the test question is very easy. Everyone can answer it. What is your favorite color? All right. So for objectives, the second one is very bright. Sorry, it projected darker on my screen. List imaging criteria for diagnosis of Chiari malformation. 2 is describe how CXA, Harris, and PBC2 measurements, I know none of that makes sense right now, sounds like gibberish, you will know a lot more in 20 minutes, are used to assess craniocervical anatomy in Chiari malformation, and discuss the method of evaluating Syrinx by MRI. All right. So this will be our little roadmap today. We've got the intro, a little bit of sort of the basic measurements of Chiari, a little bit more of an advanced discussion of measurements for Chiari, and then Syrinx with relation to imaging, and then a summary at the end there. All right. So Chiari malformation, where does the name come from? You guys may know it's from Dr. Hans Chiari. He's from Vienna, and he was an anatomic pathologist in the days, and he described that there was a malformation, an abnormality involving the posterior brain. And the posterior brain is, at least in development, very early on, in the several week stage, 3 to 4 week stage, is just 3 primary brain vesicles, of which the back of the brain is called the rhombencephalon or hindbrain. And that then divides into 5 secondary brain vesicles, and we get from the hindbrain into the metencephalon and the myelencephalon from the rhombencephalon. And then that derives into pons, cerebellum, and medulla oblongata. So these are sort of the frontal views, and the ones on the edge are the lateral or side views of sort of the whole brain anatomy and spinal cord development. And so that's how we get our anatomy in the posterior fossa. So what goes wrong? With Chiari and ultimately Syrinx, we have a normal on the left here. With Chiari 1, we get tonsils coming down into the upper cervical spinal canal beyond the level of the foramen magnum. And it comes down to the point where sometimes the CSF gets obstructed in the cord itself, and you get a Syrinx. For Chiari 2, we actually have further extension of posterior fossa contents, including the brainstem. The fourth ventricle gets completely squished, so there's no more space for it, and that usually results in hydrocephalus with dilatation of the ventricles above, and some other characteristics such as beaking of the tectum that you can see in the brain itself. So in terms of imaging, what are the options? We're not going to discuss ultrasound today because that's really just a prenatal imaging technique, and maybe shortly after birth you can image through the fontanelles. But really it's CT and MRI. So CT, as many of you have undergone probably, uses radiation. These days it's actually relatively little compared to, let's say 20 years ago. But it does use some radiation, and you can see a lot of things. This is just some random person CT I pulled up from our work list yesterday or the day before, and I put it up here. The person does not have Chiari, just to sort of see what is your routine CT able to see. So we can see the brain, we can see the brainstem, we can see the bony structure such as the sella and the clivus, which is that triangular shaped piece of bone. We see some whiteness down here. That's the upper cervical spine. This patient, I think, has some degenerative disease there, so it's very thick and sort of prominent. So on a CT head, sometimes, depending upon how the patient's head's positioned, we might cut off the bottom. So sometimes I'm looking at tonsils and I can't see all the way down, and I have to say I don't see them completely. The other trouble we have is there's a lot of bone with respect to how much stuff in terms of brainstem and upper cord we see in the upper at the craniocervical junction. So sometimes the bone is so overwhelming that there's artifact. It's called beam hardening artifact. So the artifact gets very bright and we can't really see. So even on this image, you can see that the brainstem is dark, 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 and it sort of suddenly turns bright. That's only a very mild aspect of artifact in this case. Sometimes it's very bright and I can't see a thing. So that limits what we can see at the craniocervical junction. You can see sometimes the top of a Syrinx. If you do a whole cervical spine, even a real Syrinx, you may not be able to delineate all the details of it. Because again, if you look at a CAT scan, all the tissues are very similar in density. They don't differentiate that well compared to MRI. They're all sort of one or similar shades of gray, whereas on MRI, they're much wider shades of gray. You can do what's called a CT myelogram. A few of you may be familiar with that. That's where we inject contrast. We do a lumbar puncture into your lower back, get a needle in and insert contrast, put some like 10 cc's of contrast in and circulate it in your CSF. And eventually and it outlines the spinal cord and sometimes the brain if needed, and can end up in the Syrinx over time because it circulates just like your CSF would circulate. But that's obviously an invasive way to look at a myelogram. For someone who really can't undergo MRI, that might be a possibility. So the other option is MRI. There's a lot of things going for MRI. It's no radiation. It's just a big magnet that you're sitting in or laying in, and it's spinning protons, precessing protons, we call it. And the different ways that the protons spin is how we get our imaging to have many shades of gray. It has very high spatial resolution, so I can see all sorts of tissues very, very easily to differentiate the different types of tissues. There's no contraindications known in pregnancy. We try to avoid the first trimester because that's the peak organogenesis phase. But really, we don't have anything proven as to why you can't get an MRI anytime during pregnancy. And you can image multiple times. So if the patient is uncomfortable, we can stop, take a pause, and re-image more. It does extend the exam time, but is not harmful to the patient. Some drawbacks. It is a long exam. So CTs, you could do a CT head in seconds. You could do a full, pan body sort of CT in a very little time, under a minute probably. For MR, as you've probably experienced, many of you have had MRIs, they're probably at least 30 minutes for a basic MR brain or basic MR spine. These days, we do have faster sequences. We have some techniques where you can get one or two sequences and then the computer can generate the other sequences that we used to actually have to obtain one after the other. So you can get it down as quick as maybe 6 to 10 minutes, but it's still not a minute's worth of imaging. Claustrophobia is a real concern. We have a lot of patients who are not comfortable laying in our scanner, even for a short period of time. They are larger bores now. The donut that you go in is not as narrow as it used to be, but still a lot of people are uncomfortable. I've had patients crawl out, even at the beginning of the exam, literally cannot stay inside the scanner. So we sometimes give medication like Ativan or something to calm patients down, but some really are not comfortable. So that can be an end game for someone who really needs an MR. And then some patient sizes are prohibitive. So each scanner has a weight limit for sure, but some of them, it's not the weight that's the issue. Sometimes it's the girth of the patient. We've had patients who fit the weight limit but had their arm or part of their chest pressed against the scanner inside, and they actually get burns. We had a young, I think she was a teenager, but quite overweight, and she actually had, I think her arm or her breast tissue against portion of the scanner. She got a pretty bad burn. So something to consider, that we do have to consider weight and girth. And then metal implants or metal that's retained, like if you've worked with metal and you have metal fragments in your eyes, or you've had a gunshot wound injury. Bullet fragments can have ferrous components and be magnetic and can pull and cause either heating, pain, or if it's at a vital structure, it could, cause harm. So a lot of metal implants, like pacemakers and other cardiac devices and lots of other things that are implanted, a lot of those are actually okay now. There's a lot of studies going on to basically show this, no harm done. People can't really prove a whole lot, but if you do it at the 1.5 Tesla, which is our lower clinical scanning Tesla magnet strength right now, the higher one is 3 Tesla, they're actually pretty safe. So most academic institutions, not the smaller community hospitals, will provide imaging of metal implants with consents and with backup staff available, backup faculty and physicians. So what about MR and Chiari and Syrinx specifically? So as you can see in this image, this is an MR of the cervical spine. I've put up the STIR image in this particular case just to show you. So the CSF is bright, so it's a fluid-sensitive sequence. STIR is a fancy name for short tau inversion recovery, or it's actually the acronym for the fancy name. And it just means that we suppress things to make it dark, so it's easier for our eyes to find abnormalities. So the fat in the under the skin and the fat in the bone is dark, and anything that's bright, other than discs, which are between the vertebrae, potentially could be something concerning. Like in the cord here, there's a syrinx. So this is the normal cord, and then we get this sausage-shaped area of bright signal. So that is a syrinx. So you can definitely see the structures better delineation. You can measure better, and you can define the syrinx better. If we give contrast, as you'll see later, I have an example, you can look for enhancement and nodularity. On CAT scan, even if we give contrast, it's very hard to actually see the sort of specifics about the syrinx. And then there are advanced techniques we can do at the craniocervical junction for a more functional assessment, such as Cine-MR, which I had reviewed a little bit last year, and I'll show you again briefly here, and even some dynamic imaging. At U of C, we did do some flexion extension and sometimes rotation for other atlantoaxial issues in the scanner. We would scan the patient neutral, and then we'd have them turn their heads or flex and extend their necks and scan them again to see if there's any provocative imaging findings from those changes in position. This is just a quick review of just sort of what cine MR imaging looks like. So in this case, this is done without contrast. You can probably all recognize the profile of the brain and the brainstem down here in the cord. And phase contrast technique is used, and that's just a fancy name for something that's going in across a certain plane of imaging is dark or black, and when it goes the opposite way, it's white. So your CSF is actually up in your cervical spinal canal going down and up, down and up. It's a cycle. And so we can see here in front of the brainstem and the cervical cord, there's this bright white line as I keep going. We image over and over and over and over for time. And as you can see, the white line disappears and then it comes back. So that means there's biphasic flow in that area of CSF. In the back of the brainstem and the cervical canal where the cerebellar tonsils are at the foramen magnum, I don't see that white line really at all on very, maybe a hint of it here. So that means the flow in the back is not really as robust as what's in the front, which is what is concerning in a lot of Chiari patients. Okay, so just a summary of that portion. Chiari malformation is abnormal development of the rhombencephalon, which is the hindbrain. Key findings are abnormal low positioning of elongated cerebellar tonsils with crowding of the foramen magnum, and you can potentially have a Syrinx, and we discussed the sort of plus and minuses of CT and MR imaging. All right, so now we're on to our next question, and then I'll see if I can share the screen by getting out of it. So question 1 is, Dr. Hans Chiari described a brain malformation which affects which of the following structures? Rhombencephalon, hypothalamus, cerebellum, foramen magnum. E would be choices A, C, and D, which is the rhombencephalon, cerebellum, foramen magnum, and F is all of the above. Now, I think I have to go out of this for a sec and come. Don't know why it won't let me toggle, but that's okay. Oh, it may not be activated. Sorry, I just got to the question. Now you can answer. Juggling too many screens. Okay, so now we can see live response from you guys. So how Dr. Hans Chiari described malformation which affects which of the following structures? All right. Looks like most of you have answered. Perfect. Looks like the winner is the correct answer, so I'll just show that there. Perfect. So it's A, C, and D, so it affects the rhombencephalon. Hypothalamus has nothing to do with it. It's just a structure in the midline. I threw that in there. Cerebellum, foramen magnum. All right. Now I got to jump back to this and do presenter view, and hopefully I'm in business. All right. I think I got my things going on. All right. So excellent. So first part of review of Chiari and imaging. First, we'll get through the anatomy. So for Chiari 1, which is the image on the left that I've borrowed from StatDX, which is one of our programs we use with our trainees, a really excellent program online. I don't have a license, but my trainees do, so I borrow their login. So it's the sagittal image here shows the cerebellar tonsils coming down through the foramen magnum and extending down into the upper cervical canal. It's basically to the lower edge of C1, posterior arch here. This is the bone for C1 in the back and the bone for C1 in the front. And you can see it actually reaches the obex, which is sort of the point where the central spinal canal starts, and it's actually pushed it down a little bit. It's usually a little bit more of a little check mark looking guy, and it's pushed down, it's flattened. In Chiari 2, we have a lot of other things going on. We have a smaller posterior fossa. The Chiari configuration is such that the cerebellar tonsil is really far down, peg-like, in this case, almost, sometimes almost wrapped around the upper cord. We have other findings like the fourth ventricle here, which we could see in the Chiari 1, is completely effaced. We have a beaked tectum, back aspect of the upper brainstem. We have a enlarged massa intermedia, which is sort of between the thalami. We, in this case, have a callosal dysgenesis. The corpus callosum is that big white matter tract that stretches butterfly-like across the brain. This is truncated and it's shortened. And you also can have kinking at the cervical medullary junction, where it's sort of in a sharp angle, and we also have an upper syrinx that you can just see the tippy top of. So a lot of abnormalities in this case. So the criteria that I use pretty strictly is abnormal caudal positioning of cerebellar tonsils. I use 4 millimeters for adult and 5 millimeters for children. That's what we used at Children's Hospital in Chicago. I can't say that everyone uses those numbers. You've probably seen a whole spectrum. A lot of people use 5 in everyone. This is really the proper way. If children are allowed an extra millimeter. The other point that I always talk to my residents and fellows about is that it has to be peg-like. It actually has to be an abnormal tonsillar appearance. A lot of people have low-lying tonsils that are rounded and it comes down even further than 4 or 5. It comes down to 7. But if it's rounded and there's space around it, that's not necessarily a Chiari. So there's a lot of misnomer. I see a lot of community reports come back where it looks fine and they call them all Chiari. And so that's something really to note. And so pointed, I find, is more helpful. Peg-like, I think people have different ideas of what a peg is or what a peg looks like. This is an example I just pulled off the internet. It's a peg at a bread store, I guess. But this is the type of peg you're thinking, like the wooden peg that you'd have to hammer in this case, some logs to display their bread in this bakery. But it really has to be a peg that you had to wedge in there. And so that's what that thinking of peg-like is supposed to mean. And then crowding of the foramen magnum. So you actually have to have structures that look crowded at that level. Other than that, it's going to be low-lying cerebellar tonsils, and I will be descriptive and in the end sort of conclude whether I think it's truly meeting criteria for Chiari 1 or if it's low-lying tonsils. This is a normal-ish, maybe slightly low-lying tonsil patient that I pulled off our list. This is McRae's line, which is the line that we draw ordinarily. So here's the patient's nose, their tongue, their brain is up here with the corpus callosum, cervical spine. We've got the brainstem sitting here with the pons, the fat belly of the pons, and the medulla into the upper cervical cord. I draw McRae's line from this triangle of bone called the clivus. At the base of that triangle is called the basion. I go straight back to beyond the cerebellum. There's this occipital bone, and this is the opistheon. So this defines your foramen magnum, the lower aspect of it. This is a sagittal T1 weighted image. All that means is the fat is bright and the CSF is dark. And that is the one that I usually try to draw the lines on because that gives you the best look at the cortex of the bone, which is the outer edge of the bone, to really define your basion and opistheon. It doesn't mean you can't draw the lines on a T2 or some other sequence, but you don't see it as nicely because bone is best seen on T1s. So that's McRae's line. And then we draw a perpendicular line, as you can see here, the pink line that comes down. That is the distance that we're going to measure the tonsils as. So this one's probably, I don't know, I don't have the measurement up, but it's probably 4 to 5, but they're still looking pretty rounded to me, so I'm not overly impressed. This is a sagittal T2. It's a thinner section called a 3D T2, and it offers different advantages. So I can see a lot more detail in the brain parenchyma, and I can maybe see a little bit better in the cerebellar frons and folia, but as you can see, the bone is a little bit harder to guess exactly where it ends. I can see the CSF really well at the cord level and the craniocervical junction, but I still think the measurement is better done on sagittal T1. But this is CSF is bright, and the subcutaneous fat, or fat anywhere, even under the chin, is bright. And so that's how you know this is a T2 weighted sequence. And of course, if there was a Syrinx, I would be able to see the Syrinx in the cord there. So in terms of measurements, this is a different patient that obviously has different anatomy at the craniocervical junction. Their clivus almost looks like it's laying flat instead of slanted, oblique, like we just saw. And their odontoid is retroflexed, is how I would describe it. It's pointing to the back. And so in terms of McRae's line, where I draw it here, and you can see the brainstem and the cervical medullary junction looks very strange compared to the prior one. If I draw my line here, there's no question that the tonsils are too long, too far down, and they are too thin. They look pointed and peg-like. In this case, the orange and the purple designate right and left, and these look pretty similar. This is a coronal image, imaging from the front to the back, and you can see one tonsil on one side, one on the other, about the same level. This is the axial image, and you can see the right and the left are approximately at the same level. In some patients, this is a different patient, the tonsils are at very different levels. So then I would provide 2 measurements. This is a patient that, again, I draw the McRae's line, and you can see that it is abnormally long. Tonsils look pointed. But in this case, the right one here is fatter and actually goes further down, and the left one is not as far down but is very skinny. So this is probably one of the more extreme sort of differences that I've seen in tonsils. I just happened to find a case, and you can see here that, again, this is the the right side, we're still in the midst of it, and the left, we're almost out of it. So in those cases, I would give two measurements. So in this case, I would draw the McRae's line, draw that, and say it's 16 on the longer side and 14 on the left, on the opposite side. So it's not a huge difference, but there is a difference. So when that happens, I report two different measurements. These colors are so different when they're up on the big screen. I promise they were not this atrocious on my screen. I'll fix that for next year. So I will read it to you then. So the summary is criteria utilized to diagnose Chiari malformation. I do follow that pretty strictly. I don't like to get in the gray zone. If anything, I'll be descriptive and I'll say it's equivocal if I'm really not sure. And there are a lot of patients with low-lying cerebellar tonsils that don't meet the criteria. We do the measurement in the midline for the most part if it's same measurement on both sides around the midline. If they have measurements that are different, I will provide both and designate the side. And then we talked about T1 versus T2 imaging. All right, so the next question, now I know I can switch to... Okay. Next question is, the following criteria are utilized to diagnose Chiari malformation by imaging. A is crowding the foramen magnum. B is cerebellar tonsil tip positioning utilizing McRae's line is greater than 3 millimeters in an adult. C is rounded morphology of the cerebellar tonsils. D is cerebellar tonsil tip positioning that's greater than 5 millimeters in a child. Oh, it's still not sharing. I guess it has to have me exit this to share. Okay, fancy. There we go. And then hopefully it's activated. You guys should be able to answer. E is A and B, F is A and C, G is A and D. There we go. Now people are answering. So let's see what you guys think. So A and B would be the crowding with the cerebellar tonsillar tip greater than 3. A and C is rounded morphology. A and D is tonsil tip greater than 5 millimeters with the crowding. Looks like everyone's loving A and D. Okay, a couple little other ones. Perfect. Okay, so I think the majority of you got the right answer, so that's awesome. Let me switch back. Okay. Excellent. So yes, it's crowding and then the tonsillar tip positioning greater than 5 millimeters in a child. Remember, it's 4 in an adult. By the strictest criteria. All right, so now we're moving on to more head spinning measurements. Honestly, we don't ordinarily do these. I don't routinely measure these. I'm familiar with them, and if ever requested, I'm happy to do them. But our neurosurgeons, maybe they do them on their own and don't end up bothering me because they want other stuff read. I'm not sure. But in general, we don't report these in our report, but definitely they may be terms that you've come across in your own report. So this is looking at brainstem deformity and also craniocervical instability. And the reason that they look at this is that, as you may know, Chiari is linked to a number of hypermobility syndromes, such as Ehlers-Danlos or Marfan, some of you may be familiar with. And they are diseases that, connective tissue diseases that affect joint mobility. They may have skin extensibility and tissue fragility. And it's been suggested that this hypermobility or instability at that craniocervical junction is what causes basilar invagination at the skull base or stretching of the brainstem that gives you your neurological symptoms. So assessments have been made. Traditionally, these were done, I guess, at some point in flexion and extension on an upright MRI. There was a fad, you may have remembered, when upright was really like, something that people were very into. I think that's died down. I haven't heard as much about it. I think they still do exist, but they're not as popular now. So nowadays we just do these in a normal MRI laying down, but we bump the patient's head up with a blanket or some whatever foam device we have so that they are flexed in the scanner. So we would do them in neutral and in flexion. So one of the first measurements that can be considered is a clival axial angle. So clival axial angle is just as the name sounds. As you know, the clivus is that triangular piece of bone that's at the base of the center of the brain right here. And the clival axial angle is just a line that's drawn on the back of that triangle. And then you drop a line vertical, if it will let me, along the back of the odontoid process, and then we measure the angle. And that angle, if it's less than 135 degrees, is actually abnormal. So here I grabbed something from the literature. It's flipped, so don't worry, the text is backwards. I flipped it to match the actual anatomic imaging we're looking at. So this is the normal. It's like 150 degrees. Then they had the patient flex their head, and they got something like 140 degrees. And then this is a patient with instability, and they're flexed, and you can see that it's less than 135. I think it's like 120. And you can see the anatomy has changed a lot. So basically the clivus is almost horizontal lying. We have the dens that's sort of sticking up, and you're almost at the point where the odontoid process is coming up through the foramen magnum. So that is sort of what we're looking at, the abnormal angle less than 135 degrees. So the next measurement is called a Grab-Oaks measurement. It's also known as the PBC2 line, which is quite a mouthful. So the PBC2, P stands for perpendicular. B is the basion, which is, again, that fancy name for the tip of the clivus. And C2 is the posterior inferior C2. C2 is this entire bone, right? So we need to know which part. So we have a line that you draw from the basion to the posterior inferior C2, and you draw a perpendicular line to that, to the edge of the dura, and that magically is your Grab-Oaks measurement. It's abnormal if it's greater than 9 millimeters. Oaks and colleagues showed that this measurement was statistically reproducible, and that it was a direct measurement of encroachment by the odontoid into the foramen magnum and the spinal canal. And it was felt that this encroachment was more often the cause of brainstem compression in patients with Chiari, and that measurement greater than 9 also tends to be progressive, so sort of a prognostic factor as well. The last measurement is called the Harris measurement. There's two components, a horizontal and a vertical. The horizontal is called also the basion axis interval. And the horizontal measurement is made by looking at the posterior axial line. Again, the axis is C2, so you draw a line vertical to the back of it, or parallel to the back of it, rather, and then you measure the distance between the basion and that line, and that is your BAI, or your horizontal Harris. Your vertical Harris, I know it doesn't look very vertical in this patient. I'll show you another example. You have the basion to the tip of the odontoid process. So in this patient, because their anatomy is abnormal, it doesn't look very vertical. If you do in a different patient I have here, it is actually vertical in many patients where the basion to the upper odontoid. It's because this odontoid is so far back from the basion that it's become oblique horizontal. So this is, if it's greater than or equal to 12 millimeters, these measurements are considered abnormal, and again, concerning. So in summary, Chiari 1 has been linked to hypermobility syndromes. You can assess craniocervical junction instability in flexion using these different measurements, clival axial angle, the Grab-Oaks measurement, and the Harris measurements. And then you can determine potential relative success or not of a Chiari decompression from these based on studies. So what is a way, this is the last question, I think, to assess for craniocervical instability by flexion MR, atlantodental interval measurement, CXA, Scott-Oaks measurement, oblique Harris measurement, or PCB2 measurement? And then let me get out of this. 1 second. Oh. Advance. Okay, now the question should be active, and we go into presentation. So now you should be able to key in your responses. Let's see what you guys think. We need some Jeopardy music. All right. Looks like you guys were all paying a good amount of attention. All right, we have some people questioning maybe an oblique Harris, so very close, but yes, the correct answer is CXA. Atlantodental interval is used more in atlantoaxial instability, so that wasn't discussed today. CXA, clival axial angle, is the correct one. Scott-Oaks is, it's actually Grab-Oaks. Scott-Oaks is a new dean at U of C, and I just happened to see the name. I was like, I'll use his name as a miss answer. Oblique Harris, remember it was vertical, horizontal, not oblique. And the PCB2, I just swapped it, so it's PBC2. All right, let's go back to our talk for the home stretch. Okay. So last bit is just about Syrinx, which many of you may be familiar with. So the Syrinx is just a abnormality in the cord that basically is CSF that's building up in the cord because it is obstructed. And there's multiple ways that the CSF is in the cord. There's the canal itself and then these little side ridges, side bars, I guess. And both of those need to be really obstructed to get a syrinx. A syrinx can become really septated, like in this example here. We often image with contrast, at least initially, to make sure there's no tumor or any mass that's causing the canal obstruction. In Chiari, most of the time we don't find anything, of course, but it's always better to get that done in the beginning. And then we can look at the syrinx in a number of ways. We can look at it in the length. So I usually report the upper and lower level it extends to. Once patients get surgery, often the syrinx will shrink in diameter, as well as the craniocaudal extent. I also can sometimes see the little bits of bright signal that are above and beyond the syrinx that might be considered soft syrinx, or it was a syrinx that was there that's shrunken down. So this is a T1, this is a T2. You can sort of see the difference in appearance of the syrinx. This is a 3D T2. You can see almost the flow artifact we have within the syrinx because there is actually flow going on. Sometimes in very large syrinxes, you can see very turbulent flow. And this is a CSF flow imaging, again, showing ventral CSF flow and not much flow in the back here. And you can actually see some sort of crazy signal down here. That's part of it. That's probably within a syrinx. That doesn't really look very well defined, but it is actually some flow going on. In the axial plane, we cut across the cord. I usually report the greatest transverse and AP dimension. And after the surgery is done, usually you can see it shrink quite dramatically. And I report the same level. And if there is a different level that's the maximum, I'll report that as well. This is the soft syrinx I was talking about. So the purple denotes the actual confines of the syrinx, and then the orange is sort of that fuzzy signal that I see in the cord above and below. So I will report both of those as well. All right, so last summary is the MRI is necessary to look at the syrinx itself, and you want to do post-contrast to make sure there's no mass. You assess the syrinx diameter and length, and you want to compare pre and post decompression. One tidbit is to always look at really old MRs. You don't want to look at the one just pre-op, but the one prior and the one maybe prior to that. Sometimes the changes can be more subtle, and it's easier to see if you have an older exam. And then you can always evaluate the soft syrinx component as well. So the overall summary, we talked about Chiari and the definition of it, various measurements that we reviewed to help determine if there's potential instability, especially if you have connective tissue disorder, and then syrinx measurements and assessment by MR technique. These are my references, and I hope you enjoyed that, and I'll take questions later. Thanks.